So we have a viewer whose prostate is enlarged and he has Gleason 6 prostate cancer. He's been on Dutasteride for about 6 months, but it's failing to slow his prostate growth, and he wants to know what you think he should do next.
I have a lot of patients that are concerned when they discover that they have enlarged prostates. Large prostates seem to be blamed for every kind of urinary inconvenience that occurs, but oftentimes it has nothing to do with the prostate's size. It has to do with the bladder irritability as we get older or other factors. Sometimes a large prostate does cause some occlusion of urine flow, but a large prostate per se doesn't necessarily indicate anything bad. In fact, there is some evidence that men with larger prostates who have prostate cancer have better outcomes than men who have prostate cancer with small prostates. So I don't have anything against big prostates, and sometimes that idea that gets into patients' heads that they have to stop the growth of their prostate is, I think, unfounded. It's not necessarily a disease to have a big prostate, just like it's not a disease to be tall or short or any other human characteristic. So that being said, sometimes enlarging prostates do occlude urine flow, and the Proscar, finasteride, Avodart, Dutasteride type medicines are popular medicines to try and slow that progression. But the real goal is not to slow the enlargement of the prostate, it's to ensure good urine flow. And there are other products on the market, such as Flomax, Uroxetrol, Rapaflow, that relax the urinary passages and enable better urine flow. There's products that stop bladder irritability, like Myrbetriq and Vesicare and these sorts of medicines. So the problem doesn't just simply simplify into whether you have a big or a large or a small prostate. There's a lot of other factors that translate into urinary problems, and people should focus on the urinary problems, not on the size of their prostate.
So we have a patient who's 69 years old, and over the last 10 years, his PSA started at 1.2 and has gone up to 11 10 years later. And they've had an MRI with only Gleason 6 showing. They've had it biopsied. It is Gleason 6. As I say, their prostate size is about the size of a 40-year-old, and that they've had the Prolaris DNA test, which says they have non-aggressive cancer. Because their PSA has gone from 1.2 to 11 over the past 10 years, they're wondering if there's anything that they should do.
For a long time, PSA was the only indicator we had to determine if there's going to be a problem with prostate cancer, and it's roughly useful still to this day. I tend to think of PSA in increments of 10. So low risk is like from 1 to 10, intermediate risk is from 10 to 20, and high risk is 20 and above. Sometimes when we share that with people, they realize that these changes now, smaller changes, don't have that much relevance. But in this case, the PSAs jump from one category to the other. They mentioned that their prostate is normal size for his age, and that would maybe be about a 40 cc gland, and a PSA of 11 is a little higher than you would expect. So is the low-grade prostate cancer causing the PSA? It's not an enlarged prostate that's causing it. Is it prostatitis, some sort of low-grade inflammation? That needs to be looked into. The process that they've used so far sounds very reasonable, and it sounds like they have looked into it. So after thorough evaluation, if you don't find a reason for the PSA to be elevated, we typically check the box and say it's probably some inflammation or maybe the low-grade cancer, and we continue to watch the situation. It's been fairly conclusively agreed upon by experts that PSA by itself is not the reason to abandon active surveillance. The reason to abandon active surveillance is if you have a biopsy-proven change that is no longer Gleason 6, that the grade has gone higher. So while it does create some consternation and concern and worry when PSAs go up, people do need to look for the reason. We don't always find a perfect reason, but we don't use that as a trigger to stop active surveillance. One of the backstops, I think, that's going to be used more frequently in these people that have high PSA density that are under surveillance is the PSMA PET scan. And that's another way to assure and ensure that the very thing we fear hasn't happened, that is spread outside the prostate, or that there's another cancer somewhere else in the prostate as yet undiscovered. PSMA PET scans are good for both finding new cancers in the prostate, and of course, making sure that there's nothing outside the prostate.
So for his particular case, how often would you suggest getting monitored? Like his PSA getting checked or maybe imaging?
Yeah, we check PSA 2 or 3 times a year in men that are on active surveillance, and we do color Dopplers and MRIs once a year. And in the men that have high PSA densities, some of those we've been getting PSMA PET scans.
What is the latest research on taking holidays from ADT, and when do you recommend they start ADT again? So what are the markers of restarting ADT when somebody does take a holiday?
So intermittent hormone therapy is a vast subject, and it is well established that it's a safe proposition. We reserve intermittent hormone therapy for men that have been able to get undetectable PSAs while on hormone therapy. So people that go on hormone treatment and can't get their PSA all down to less than 0.1 or down to less than 0.05, in my opinion, are usually not candidates for intermittent therapy. But those that do, usually a PSA endpoint is utilized to restart treatment if the PSA rises up to 2 or 1 or 5 or something of that range. Some centers have said as high as 10 or 20, which seems a little bit high. I think this is now changed because of the PSMA PET scans are coming, where in the past we didn't have any way to find where the PSA was coming from. So we just kept going off and on hormone treatment over time. Now, with PSMA PET scans, we can detect where the cancer is coming from when the PSA is less than 1. And so I think the logical sequence going forward is going to be stop the hormone therapy, and then as the PSA starts to rise up to 0.5 or 1.0, get a PSMA PET scan, and if there's a limited number of spots of cancer visualized on the scan, then to usually administer radiation to eradicate them and try and control the disease both with the hormone treatment plus targeted radiation.
Thank you so much for watching. If you found this information helpful, you can visit our website, pcri.org, and consider a donation. Also, subscribe to our YouTube channel. We come out with new prostate cancer videos every week.